I'm going to be talking about our recent quality improvement projects. We have started the joint surgical and anaesthetic pre-assessment clinic focused on elective abdominal aortic aneurysms. So I'm going to start with a little bit of an introduction about the project, talk about some of the backgrounds of the AAA guidelines, which is largely forms the basis of most of the discussions we have in clinic and also the decisions that we have to make as part of the process. Talk about why we're doing a joint clinic rather than carrying on as the way we were, how I run the clinic, and then we'll look at some of the data of what impact the clinic has had, and then also discuss potential future improvements. So this was originally started by, back at the beginning of 2024 by Andrew Batchelder, who is the lead vascular surgeon, and Richard Sinner, who's our vascular anaesthetic lead, and also David Evans, who's our preoperative lead. And the main aim of the project was to try and reduce the waiting time from booking to surgery. And then as part of this, we're also trying to improve our MDT approach to pre-assessment, which falls in line with some of the recommendations put forward by the Vascular Society's Quality Improvement Programme, which I'll come on to discuss in a bit. And if we reduce the time from booking to surgery, we'll hopefully reduce the number of patients whose aneurysms rupture whilst awaiting surgery, which again, I'll come on to cover shortly. So like I said, I'm going to talk about the background and guidelines that are out there currently. So just a little bit of stats to start with. So the definition of an abdominal aortic aneurysm is there is a dilatation of the aorta within the abdomen of more than 50%, and that's the anterior posterior diameter, or an infrarenal diameter of more than 3 centimeters. The large majority of aortic aneurysms are infrarenal. About 5% involve the renal or visceral arteries, and those are the ones that require a more complicated surgery, either a complicated open operation or a fenestrated endovascular repair. And about 40% of aneurysms also involve aneurysms of the iliac arteries. It's become increasingly more common over the past 50 years, probably largely due to the surveillance and screening programs that are out there and awareness that this is a problem. The large majority of aneurysms are asymptomatic. It's about 4 to 8% of men aged 65 to 80, and it's much less common in women, about 1.3% of a similar age group. The main risk factors, other than age and male gender, are positive family history, like other cardiovascular disease. But the big one, and it's also very modifiable, is smoking. So you're 4 times more likely to have an aneurysm if you are a smoker. And if you continue to smoke with an aortic aneurysm, it's been seen that they increase in size more rapidly. And as you can imagine, the most common cause of these aneurysms is atherosclerosis, which would fit into that profile. So back in 2008, the UK was seen to have a significantly higher mortality with respect to abdominal aortic aneurysms compared to the rest of Europe. It was 7.5% in the UK, but 3.5% across the rest of Europe. So the Vascular Society obtained a grant nationally to start the Abdominal Aortic Aneurysm Quality Improvement Programme, with the aim of encouraging best practice, reducing the variation of care between different sites, and then overall try and reduce this mortality so that we're back more in line with the rest of Europe. The main recommendations from this programme, which is something that we're trying to fit in with our clinic, is to have a multidisciplinary team approach to pre-assessment, and something that they suggest is to have a MDT meeting that includes a vascular surgeon, a vascular radiologist, and a vascular anaesthetist, which is something that we do, and we've tried to incorporate this MDT approach to this clinic that we've started. Having centralized services so that centres perform more procedures has been shown to have a reduced risk of complications. So they aim to, rather than lots of little hospitals doing 1 or 2 aortas a year, they are centralized to either a tertiary centre or a bigger centre near to the smaller hospitals. They recommend shared decision making and basically all the information and evidence regarding their aneurysm care should be given to the patients in the format that they can digest and be involved in the decision making. And then I've also started the national clinical audit via the National Vascular Registry, which produces data on surgery, mortalities, waiting list times, lots of different variables, and it produces a report quarterly. Another thing that was set up at the same sort of time was the National Screening Programme, and this is where we get a lot of our referrals. So it was seen that evidence that at the time, 2009, suggests that screening could halve the number of deaths related to AAAs in men aged 65 to 75. So once you reach the age of 65, you are now offered screening scans. If you are found to have an aneurysm and it is more than 5.5 centimeters, then you are considered for intervention. If the intervention is thought to be appropriate, then you should be aiming to have this intervention within 8 weeks. And the national target is that 80% of patients get this intervention in that time period. The NICE guidelines for the same thing, as if they have an aneurysm bigger or equal to 5.5 centimeters, they need to see a surgeon within 2 weeks. If they are between 3 and 5.4 centimeters, then they can see a surgeon within 12 weeks. And has it helped? So since starting these 2 initiatives, the overall mortality for AAA repairs has reduced. In 2010, it was 2.4%, and it's now down to 1.4% for both open and EVAR procedures. Open operations have a higher overall mortality of 2.3% and have a longer length of stay of about 7 days. And EVAR procedures have a mortality of 0.4%. To make things easier numbers, I usually quote a mortality of about 1% for that. And they are often in hospital for 2 to 3 days. So when do we think, other than obviously the size of the aneurysm, patients that have an aneurysm that's bigger than 4 centimeters is asymptomatic but is growing fast, so more than 1 centimeter a year, they will be considered for an operation. Or if patients are symptomatic, so classically it's sort of lower back pain or abdominal pain in combination with an aneurysm. Below the sort of threshold size of aneurysm, there's no survival benefit seen between surveillance and surgery, which is why we don't offer the surgery before we get above that threshold size. And the rupture rate for patients with less than 5.5 centimeter aneurysms is less than 1%. So less than 1 out of 100 people within the year will rupture. Whereas once it gets bigger than 5.5 centimeters, it's unclear exactly what the risk of rupture is. It's somewhere between 1 to 5%, depending on the patient and the characteristics of their aneurysm. Female patients have a higher risk of rupture, and this is commonly because they are of smaller stature, so an aneurysm of that size is bigger with respect to them compared to a similar size in a bigger male patient. And for whatever reason, we're not quite sure, their aneurysms do seem to grow faster than in male patients. So they might fall into that growing faster than 1 centimeter a year group. We then need to decide what operation we're going to offer, if that's what we're going to do. So the big classic decision is open or EVAR. So open operation is a laparotomy where you put a cross clamp across the aorta, you open up the aneurysm sac, and you stitch in by hand a graft, as you can see on the left. Whereas an EVAR operation is a radiological procedure performed in the angio suite, where with the help of X-rays and various wires, the graft is put into place to try and wall off the aneurysm sac to prevent it from growing larger. And this is where it's a sort of fairly controversial evidence currently. So current evidence for EVAR in unruptured aneurysms is that there is a lower operative and 30-day mortality. So the initial risk that you are putting yourself under is lower than an open procedure, which would make sense. But there's not a significant survival benefit at a 5-year point. And in fact, there are increased risks of needing further operations due to the aneurysm growing despite your endovascular graft. And because of this, it's not thought to be being particularly cost effective for the NHS. After about 8 years, there is an increase in all-cause mortality and aneurysm-related mortality for EVARs with respect to open operations. And then one trial has shown that there's actually a similar 30-day mortality for open and EVAR procedures. However, for ruptured AAAs, they have a similar 30-day mortality, but with an EVAR for a ruptured AAA that is supposedly shown to show a reduced length of stay, more likely to be discharged home, and more likely to lead an independent life. So this has led to relatively controversial NICE guidelines initially. So the draft recommendations in 2018 suggested that EVAR wasn't to be offered for an elective open AAA, and if the patient was fit, they should be offered an open operation, and then EVAR would be reserved for ruptured AAAs, so you could offer both open or EVAR for a ruptured AAA. As you can imagine, this caused quite a lot of upset amongst the vascular community, specifically if surgeons who were specialising in endovascular repair and felt that this was a legitimate technique. So this led to a U-turn from the NICE team when producing the guidelines, and this was without the clinical guideline committee's support. So what they're saying now is that you can offer an EVAR for unruptured AAAs as long as the patient is given all the information regarding the durability and the increased long-term mortality, and that it's an expensive procedure that's not cost-effective to the NHS. That little line I've put in there is largely verbatim from the NICE guidelines. So currently, in our clinic, if the patient is medically fit with a life expectancy of more than 8 years and it's surgically possible, then we should be offering an open operation. NICE guidelines also have some recommendations about how we estimate risk in our clinic. So I know that in pre-op it's very popular these days, and I've used them myself, to use risk models such as your SORT or your NSQIP risk calculators. For AAAs, the NICE guidelines don't recommend using those. They feel that they have a lack of evidence, they have a low positive predictive value, and are potentially causing harm by either offering operations to people that we shouldn't and vice versa. But they do say that we can use them to supplement clinical judgment and our overall assessment of the patient. There's a little bit more evidence with regard to CPET, but not a huge amount. So there is some evidence that low or sub-threshold values of certain variables that we measure at CPET, such as your anaerobic threshold, your VO2 peak, or your VE/VCO2, are associated with a reduced life expectancy after an elective AAA. We have quite a low threshold for ordering CPET tests, as long as the aneurysm is less than 8 centimeters in diameter, which is your cutoff before it becomes more dangerous to do the CPET test. Any of you that do pre-op and have logged into our cardiology meetings know that serum markers are becoming more popular. I've been using BMP in both my standard pre-op and our aortic clinic, as there is an increased evidence that they are a good predictor or a reasonable predictor of perioperative cardiovascular complications for non-cardiac surgery. So it is something that we can add in to help gauge cardiovascular risk. So why have we started a joint anaesthetic and surgical clinic? I've sort of mentioned some of the aspects at the beginning, but the way we used to do it is that patients were seen separately by the surgeons and then referred to B50 clinic. They then obviously see an anaesthetist and a nurse. The anaesthetist ideally would be a vascular anaesthetist, but this is not always guaranteed. And then any concerns we had regarding what surgery was being offered, whether they were fit for the surgery, whether or not various other discussions needed to be had, often needed to be done via email or phone. And this could lead to significant delays to getting the patient to the operating theatre. So as I mentioned, if a patient is to have an intervention, this intervention should be done within 8 weeks. That's the national target. And if the patient was to rupture their AAA after 12 weeks, then this should be reported as a serious incident. There are some mitigating delays. So the valid delays are, so if the patient's been seen in clinic, but they aren't for surgery, so they, on review of a CT scan, they don't have an aneurysm. If the patient decides they don't want an operation, or if the patient is not suitable to have an operation, then those are acceptable delays, obviously. If the patient is awaiting a stent, so FEVAR operations are sent off to Australia with their to be handmade with respect to their CT scan images. So currently it's about a 6-month wait for a FEVAR operation. So that does skew our results with respect to our waiting times to some degree. And then if the patient has a significantly complicated aneurysm that needs to be referred to a specialist centre there, then those delays are allowed. Delays, as you can imagine, that aren't allowed there are hospital factors such as delays in receiving tests, it's administrative delays, staff illness or leave or lack of beds. So how does the clinic work? So it's every Friday afternoon, and it's alternate either myself or Ollie Morgan. We're in a central hub where the vascular nurses, the administrators, the surgeons and myself are all based, and we're able to discuss the various patients. We review new and follow-up patients for AAAs, and then I either do an individual or a joint consultation. Originally, I did joint consultations for all patients, but it lacked efficiency. If the patient was straightforward, the surgeon would sit there quietly whilst I discussed epidurals and vice versa. So if they are a straightforward patient, then I may let the patient be seen by the surgeon first, and then I will go in and see. If it is a patient that is more complicated and needs a more holistic discussion, then I'll go in together. We come up with a plan, we order all the various tests, including CPET tests or various things that we need, and then they are booked for a B50 nurse-led clinic, so they have to come back to clinic for their blood tests and ECGs currently. And most, as you can imagine, most of our referrals come from the national screening pathway, but we do get a lot of incidental CTs as the AAAs are usually asymptomatic. They often have a CT scan for something else, so either having a malignancy investigated. Other ones are the NHS targeted lung health checks. I believe it's after the age of 55, I believe. If you're an ongoing smoker, you offered a CT test to review for COPD or other lung pathology, and quite often we see those patients having also found a AAA. And then what do I do in the clinic? So I went to a recent anaesthetic vascular conference, and one of the speakers had just produced these NHS England decision-making aids, and this was the Abdominal Aortic Aneurysm, and it's a really useful document. It's a patient leaflet, but it's a great framework for how I sort of discuss aortic aneurysms with my patients, and also gives you some great ways to describe risk. And there's just some examples of some of the things that are contained in those documents. So I try and sort of structure my discussion around that document, and it encompasses a lot of the things I've already discussed. and also tries to follow NICE guidelines. Like I said, we have a low threshold for ordering CPET tests. And despite the risk calculators not being recommended by NICE, I do use them, particularly in patients who have significant comorbid burden, as it gives you a nice, the NSQIP document gives you a nice visual aid showing patients who are significantly above average risk, lots of red graphs, and it's quite a useful diagram to show patients to suggest that they may not be as fit as they feel, and that they are at an increased risk having this surgery. And has it had an impact? So this is from the National Vascular Registry, looking at the national time from booking to surgery. On the right-hand side, you can see there's a red dotted line, which is the national target of 80% of patients having their surgery within 8 weeks. And the national average is at about 30, and it's fairly consistent and has been for a few years. So we're significantly below where we should be nationally. And then you can, on the registry, you can put in NUH. And we were towing the line at 30% prior to starting our clinic. And then we started our clinic at the beginning of 2023, 24. And as you can see, there's a little dip, and then we've had a gradual increase. So we're now up above 60%. So not quite at the target we want to be, but we've had a significant impact on the reducing the waiting time between surgery, booking and surgery. We've looked at the individual data we've got on our database as well, just to see, to get a better idea of how we're doing. So 6 months prior to starting the clinic, there were 49 patients in total. 19 did not have a repair, and this was a combination of either patient choice or significant comorbid burden. There's one patient who had to be referred to Birmingham due to it being complicated with a dissection, and then 29 patients proceeded to surgery. And then the 6 months after starting the clinic, we had about the same amount, so 52 patients in total. 36 were for conservative management, and 22 were turned down by the surgeon, having not been seen by an anaesthetist, and 14 were seen by both. And 16 proceeded to surgery, of which 13 were seen in the joint clinic. Again, looking at our waiting time from booking to surgery. So before the clinic, there was a mean wait of 29 days to see a surgeon, 80 days to see an anaesthetist, and then 161 days from booking to surgery. So that's 23 weeks, so significantly above the 8-week target. And then the 6 months after, we had 16 days from booking to seeing a surgeon, or from diagnosis to seeing a surgeon, and then 21 days to see an anaesthetist, and then time to surgery was down to 64 days, so 9 weeks, so very close to where we should be. So that should have a significant benefit on reducing the risk of having a rupture whilst awaiting surgery. I don't have the official numbers because they are quite small. I think the last few years we've had 1 or 2 patients rupture whilst awaiting surgery, and so far this year we haven't had any. So it's difficult to say if that's due to our clinic or just due to the statistics of it being relatively rare, but it can't be a bad thing to be getting close to the national target. My perspectives on the clinic. So I very much enjoy the clinic. You're sat there with a team, you're able to discuss the patients, and you can have I feel like we've got enough time in that clinic to have a proper holistic discussion with the patient and their family. And I feel that by the end, everyone's on the same page, and patients leave happy, even if the decision is that they may not be appropriate to have an operation. I feel that having had these discussions, they're happy that is they understand that, and it's a good decision. How we can improve in the future. So currently, the original plan was to have the vascular nurses trained up to do the electronic pre-op bit that the B50 pre-op nurses do, so that it was all done in-house. But due to various funding issues and other hurdles, this was not possible. So they still need to come back for a B50 pre-op clinic. And I think in the future, if possible, if we were able to do it all in-house, it would be a one-stop shop where the patient can come in and see everyone, do all their tests, and then they'd be ready for surgery. And I know other centres have got radiologists and/or healthcare of the elderly specialists in their joint clinic. So if we were able to recruit one of each of those to our clinic, then it may further improve the clinic moving forward. Just like to thank Mike and Snare, who looked through our local data for us and produced those nice graphs for us to show that we're improving our waiting times. And then I've not been able to look at the chat, so just wondering if there are any particular questions from anyone out there, because that's me finished.